Cultural competence is a critical skill for therapists to have in their work with all clients. It recognizes that mental health and symptoms of disorder occur within a cultural context. Therefore, culture must be meaningfully considered in assessment, diagnosis, and treatment. I'll be presenting a model that can help therapists be attentive to the multifaceted nature of cultural identity and will provide ideas for how to begin to talk about culture with a client. An American psychologist, Pamela Hayes, created the addressing model as a way for therapists to consider various aspects of identity and the privilege and oppression relevant to each. Understanding a client's multifaceted identity allows the therapist to be mindful of how a client is treated and responded to within the culture in which they reside. In other words, it allows a therapist to begin to develop a more nuanced understanding of a client's experience of life, with the possibility of then framing client symptoms and identifying treatment options in the context of a client's cultural experience. It also allows a therapist to be mindful of ways in which the therapist and client identities interact, to better anticipate factors that might impact trust, rapport, and therapeutic alliance, aspects of a client's identity for which a therapist might have biases or assumptions, aspects of a client's identity for which a therapist has insufficient knowledge, ways in which the therapist's privilege or marginalization in each aspect of identity might cause them to over-identify with clients in certain areas or might blind them to the experience of the client, and the need to be more attuned to client experiences, especially when the therapist holds a privileged identity and the client holds a marginalized identity. The therapist can also attend to the intersectionality of identity, or how the combination of two or more aspects of identity may lead to a different experience than having just one or the other aspect, but not both. An important aspect of the addressing model is a recognition that each aspect of identity includes privileged as well as marginalized or oppressed identities. For example, in U.S. society, the following identities would be privileged. Similarly, identities that fall outside of these privileged categories, such as being elderly, transgender, Muslim, or bisexual, could result in differential and discriminatory treatment within the culture. These aspects in the addressing model and the associated privilege and marginalization identified for each are not necessarily universal, given the development of the model within the U.S. context. However, they provide a framework for considering relevant areas of identity, privilege, and marginalization in other cultures. When considering different aspects of cultural identity, a therapist should be mindful of several things: how each aspect of identity has affected the client and the client's experiences, both in childhood as well as in adulthood; how the therapist's view of the client is influenced by the therapist's identity in each category; how various aspects of identity intersect; and how the therapeutic relationship might be impacted by the interaction between client and therapist identities. Additionally, a therapist would want to ensure that they move beyond simply identifying demographics and instead think more complexly about how that aspect of identity may have impacted a client. For example, it would be insufficient to simply note the age of a client. Instead, when considering age and generational influences, a therapist would be mindful of societal expectations when a client was born, particularly given other aspects of their identity such as race or gender, norms, values, and gender roles within the client's family, peer group, racial ethnic group, and dominant culture, social movements that occurred during the client's childhood or early adulthood, and how those impacted the client or shaped their view of life, educational and occupational opportunities available to the client in early adulthood as well as in the present, and generational roles, such as parent, grandparent, aunt, that are part of the client's core identity. Similarly, with developmental disabilities and disabilities acquired later in life, a therapist would consider disabilities for the client, whether the client was raised with a parent, sibling, or other caregiver who had a disability, and additionally, whether the client is a caregiver for someone with a disability. If a disability is present, it can be helpful to know how the disability affects relationships within the family or with others with whom a client has close contact. It may be necessary to provide a client with examples of disabilities, as some clients may not perceive an ongoing medical issue, such as lupus or diabetes, or mental illnesses such as depression, anxiety, or schizophrenia, as a disability in the same way that they perceive being blind, deaf, or physically disabled, even when the disability interferes with functioning. In the area of religion and spiritual orientation, a A therapist should ask about both the religious background of a client as well as how their religious and spiritual practices may have changed since childhood. Not only do such questions provide a more nuanced understanding of religion and spirituality, but the questions indicate to a client that the therapist will value the discussions about the role of spirituality in their treatment. A client may be hesitant to discuss religion or spirituality if they perceive a therapist to lack understanding of their religious background or expect a therapist to be judgmental, necessitating that a therapist communicate openness to client experience. As with religion and spirituality, in some cultures, ethnic and racial identity can be a difficult topic to talk about without prior trust and rapport, particularly if a therapist holds a dominant ethnic racial identity and a client holds a marginalized identity. It may be appropriate to ask how it is for them to be someone of that racial ethnic identity in particular contexts, for example, at school, in their job, or in therapy. Questions about socioeconomic status should address both the economic circumstances in which a client was raised as well as their current economic circumstances. A therapist can consider how social class is evident in a client's occupation, income, education, marital status, gender, ethnicity, or community, and should be mindful of the role social class plays in a client's presenting issue. As with other aspects of identity, sexual orientation may be a sensitive topic to talk about without prior trust and rapport. A therapist must be aware of the setting in which they are practicing. This could affect whether a client who is gay, bisexual, or pansexual would be fearful about repercussions of coming out to the therapist, or whether a client who is heterosexual is offended by the questions. When asking about sexuality, therapists should avoid gendered language, such as asking whether a client has any boyfriends or whether the client is married. Instead, the therapist can simply ask whether the client is in a relationship and to describe prior intimate relationships. By using non-gendered language, the therapist allows the client to specify gender and also communicates that the therapist is not assuming a heterosexual identity. For clients who disclose marginalized sexual identities, it would be important to understand how family and friends have responded to the client since coming out, or what impact this identity has had on them or in their relationship with others. Indigenous heritage refers to whether a client comes from a tribal or other group of people who would be considered the original native population of a country. Examples include First Nations, Ainu, and Hmong peoples. Similarly to questions about religion and spirituality, a therapist would want to understand how this has played a role in the client's life and the meaning of Indigenous identity for the individual. National origin refers to the nationality of the client and the languages the client speaks. It also includes information about whether the client is currently residing in the country in which they were born and raised. Gender refers to identity as well as gender roles, expectations, and relationships. In other words, not only whether a client is female, but also whether that client has the role of mother or daughter-in-law or oldest sister, and what expectations come with that role given the client's family culture as well as broader culture. For example, are there expectations of a married woman to have children, or to stay at home and care for the children? How does society view an unwed mother, and what repercussions does she experience for having that identity? Using the addressing model in a country other than the U.S., a therapist should consider other aspects of identity that may also be relevant in the culture that the client is from or in which they reside. In the Indian context, the therapist may consider identities based on caste, language, or region, urban versus rural residence, or educational attainment. Physical characteristics, such as skin tone, hair color or texture, height, body size or type, facial features, or physical blemishes, may also be relevant in some societies. Therapists should be sensitive to the fact that some clients may not want to talk about cultural identity, particularly early in therapy. Clients may see it as irrelevant to why they came to therapy, or they may be hesitant to talk about more personal aspects of identity early in therapy before trust and rapport has been developed. Therefore, although cultural identity should be explored early in therapy, some issues may require trust and rapport in order to explore more fully. Revisiting these issues throughout therapy may bring out new and clinically relevant information. I hope the information provided today allows for a better understanding of clients within their cultural context, bringing culture more fully into assessment, diagnosis, and treatment. Thank you.